My name is Adam, Content Marketing Specialist with Henry Schein, and I'll be your moderator. I'm pleased to be joined by Dr. Don Murray. Dr. Murray will be discussing and reviewing 3 challenging cases from his practice and how he has used the full Planmeca digital workflow to diagnose, plan, and treat each case. Before we begin, I'd like to remind all attendees that today's webinar is being recorded and everyone will receive the link of the recording in the next week. If you have questions for Dr. Murray at any point during the webinar, please type them into the Q&A and we will answer them live at the end of the presentation. This webinar is presented by Henry Schein Dental and sponsored by Planmeca, and no CE credits are being offered for viewing or attending this webinar. With that, I'd like to hand it off to Dr. Murray.
Thank you, sir. Appreciate it. Welcome, guys. Let's dive in. I'm excited. I'll tell you a little bit about myself and my practice as we go along. There'll be a lot of tangential learning topics. I'm very clinically driven, but I also want to impress upon the efficiencies and effective workflows that allow digital dentistry to be the center of your practice and to push it further than you probably ever think you could have. So thank you for Henry Schein and Planmeca for supporting this in this venture of ours. So a little bit about myself. I am married with 2 kids. I come from a family of dentists. My dad is a dentist. He is slowly phasing out of our practice. He started in 1984. My brother is a dentist, a partner of mine. My sister-in-law, my wife's dad, 2 of his brothers, their dad was a dentist. So lots of teeth talk at the dinner table. I went to UVA, University of Virginia, and graduated in 2006. 2010, I graduated from Case Western in Cleveland, Ohio, and I'm now a multi-practice owner in Richmond, Virginia. I'm a president of to be named later in the presentation CE company, which we'll talk about. I'm a key opinion leader for Planmeca. I lecture for them internationally, and I'm also on their board of education. So lots of Planmeca in our practice. So are you numb yet? That's quite a question to ask right now. We're in the craziest times. Certainly of my career, I'm assuming the career of everyone who's listening to this. It's wild. It really is. I hope you guys are all hanging in there. I keep telling my team it's an interesting time in that patients don't seem to be the rate limiting factor in this whole thing, which I'm certainly impressed upon. The case acceptance and the dentistry our patients are looking forward to getting, hearing about, getting, and then getting is pretty incredible. So crazy town. This is most of the practices I encounter. This is where they stand. We're a very big PPO-driven practice. We'll talk about how we can maximize that further in this lecture. But PPOs are interesting, right? They are what they are. I've seen online recently a lot of insurance companies are actually emailing dentists. This is quite a time for them to be saying this, but that they're dropping their rate schedules, fee schedules, which that's wild. Anyways, clinical monotony. I came from the type of practice where we just drill, fill, full coverage zirconia crowns. How fast can you prep and get out the room? It's just boring. Daily drama. You guys understand that. I don't have to explain that at all. Staff is just disinterested and not interested in anything you're doing. Tons of patients, lots of volume, overworked. I'm sure a lot of you guys are like that. I actually felt like that today. Why digital? Lots of opportunities, certainly a huge return on investment. We'll talk about that. PPO is basically a gateway for our patients. So, we consider PPO insurance our marketing, our biggest marketer, and we get them in the door, and then we coach them through and present the value of the more advanced dentistry we do. Sometimes they have coverage for that. Sometimes they don't. But it's just the gateway. It's a low barrier to entry to get patients in the door, and then we take it from there. Clinical variety. There's lots of different options afforded you by getting into digital dentistry. We'll certainly talk about that. A lot of it can be delegated. It's very cool to see an uninterested team go to training somewhere and then become rock stars in, putting out super aesthetic number 9 EMAX crowns for you. You get the team re-engaged. A lot less patients. I have an associate that works beside me, and her perfect day, and she gets them most days. She does 3 or 4 same day cases, single units with a couple fillings or quadrant of scaling or something else in the mix. and they're dream days. And I'm a little bit jealous that this quickly she's learned the secret sauce to how to be successful. Here's my dad. 1984, he started a practice, 2 or 3, I think it was 2 operatories. We now have 3 practices, 35 operatories, looking at another one. So a little bit different, but it's crazy that, the problems that he was solving to make his 2-room practice successful, the same problems to a degree that we face and all of you face. And so these are, I was trying to think of what translates from back then to now to even during COVID. And these are the kind of things that have helped make us successful, that we're treating our patients and our teams well. Work smarter, not harder. I think that's self-explanatory. Ability to provide the dentistry that your patients want and need. It's with the lack of expanse in what's being taught in dental schools, it's a little bit scary. And to get out and just not be able to provide the type of dentistry that your patients need, such that you're referring them out on a regular basis, is, I think, a no-win for everybody. It's certainly a no-win for your bottom line, but patients nowadays, they just want to they trust you. They understand you're presenting the value of the dentistry to them. They just want you to do it and never stop striving to get better. Here's me, my dad, and my son this is when UVA won the national championship last year before COVID happened. So we're still the defending champions. That was right. The left picture was right after the confetti came down when they won the game. And if you watched the game, it was a pretty incredible game. It was a fun run. It was very surprising, but we had a good time. That was a pretty magical experience in our lives. So let's talk about my digital timeline. I first started investigating digital dentistry in 2012. I would get on eBay every day and see. I didn't know what anything was, but I knew that scanners were super expensive. So I was looking at the cheapest desktop scanner I could get into my practice and just get my hands wet. And our Shine rep took us up to Baltimore Orioles Stadium, and we saw Alex Touchstone speak. There was about 300 people in the room, and we were sold. He just had us jazzed about E4D, and at the time we had 2 offices. And so we had the papers in the car. We were ready to sign. We got home for 2 full systems, and we actually got a phone call from another Henry Schein rep who said, hey, there's an office that is coming on the market. So the price actually was very similar. So we bought a 3rd office instead of 2 full systems and paved our way to where we are now. And then I put it away for a second, and I had this graduate student come to my practice out of the blue, and he was a part of an angel investing project, and they had purchased 15 or 20 3Shapes. They had a connection at a cosmetic lab in California, and the idea was they would give you the scanner for free, and you would sign a contract for X number of units per month. There was a significant write-up on the units. First 2 months, awesome, really cool. I didn't even touch the scanner. I let my team teach themselves. And then the 3rd month, I ran the numbers on what kind of money he was making on us. And I was like, okay, that's it. I appreciate the intro to digital dentistry, and we don't need you anymore. So we went to a centralized mill where we had a scanner at each office, and we would scan, design, and then send that restoration virtually to the 3rd office, which had a milling station. It was great. It worked well. It was like having a lab that was sort of inside of our walls. The problem became when Tanya was mad at Brandy at the other office because she didn't stain the gingival 3rd correctly. And just nonsense like that. It just became inevitable that we would look at something more. So we ended up getting full systems at all our offices. We now have fully integrated with 3D printers, iTero scanners at all the offices. We do pretty much everything there is to do in digital dentistry, except dentures. I haven't got into dentures yet. In 2017, we really went ahead first into 3D printing and have not looked back. I think for a while there, the thought was maybe 3D printing can replace CAD/CAM milling in an office, and that's maybe possible in the future. But now I just see it as an augmentation, a way to expand the horizons even further. There's things that we can do on the 3D printer that make it a little bit easier than we used to on CAD/CAM, and then vice versa. So PPO dentistry, no bueno. This is not an ego slot. I just want you to understand where I come from, that the model can be successful, that you don't have to just drop all your insurance companies overnight because the fee schedule is not great. There's a way to maximize the type of dentistry that can be done through PPO driven practice. So again, we're doing everything digital now. Sleep, we do sleep in our practice. We're taking impressions for that digitally. We're doing ceramic, partial and full coverage ceramic restorations. I haven't sent a restoration out to the lab for a single unit in probably since 2018. We do 3D printed hybrids. We're doing 3D printed night guards now, fully digital implants. We'll talk about that. So really, really cool stuff. So yeah, you got it. Like, would it work for me? Right? Well, I think it can work for everybody, but this is what we are experiencing. And I know the reps have quite an interesting time right now because, you know, it's like we're just we get deliveries of masks and everything every day. And, you know, is it a time to spend $100,000 on a digital dental system? You know what? I would tell you there's not a better time. That may sound crazy, but the options it affords us, yeah, I would do it all over again in a heartbeat. So here's a study done in 2010, USA Today. This is really scary. I love my job, but I am a little bit offended that people are more scared of us than going to DMV or doing their taxes. That's pretty crazy. So what's the most important to the patient? I'd be interested to hear your thoughts, but it's been studied in the literature. And the two things they're most afraid of are the shots and the impressions. And so I think sometimes we kind of lose track and we're running through our day. And again, single unit, 20-minute Bruxer crown prep, in and out the door, PVS impression in the mouth. And we kind of lose track of what that experience is like for the person on the other end of it. How about a scanner? So much easier, cleaner. It's a wow factor. Patients really, really enjoy it. I'll let you laugh at this.
Now, we're going to have to make an impression of your mouth. I've got a little treat for you. Robin, bring in Stephen Baldwin's mold for Doug to look at. Open wide. All right, now bite down. Okay. Through your nose. Just breathe through your nose. Don't panic.
Yeah, so a scanner, and if you've never seen the Emerald scanner, it's pretty impressive. It literally is the size of your fingertip. There's a slimline tip on it that's even smaller. Bonkers. Super good scanner, super good tips. So much research put into it. So we have Emeralds at all our offices. There's sort of a misnomer if you haven't done a lot of research or heard in the last 5 years, maybe even longer than that. But if it's been a while since you've looked into what intraoral scanning or CAD/CAM milling can do, it used to be that there was a lot. We had to spray things to be able to even see them. That's certainly for the past. Again, study after study, we won't bore you with it, but understand that patients certainly prefer the digital impression to analog. But is it accurate? Well, let's talk about that. How accurate are PVS impressions these days? Not that accurate. This is a study in the Journal of Prosthetic Dentistry back from 2005. 89% had one or more observable critical errors. 50% have deficient margins from Gordon Christensen. And then in 2015, in JADA, 86% had at least one detectable error from 3 labs. So what you think may be super accurate, I think you'd be surprised at how inaccurate it can be, especially understanding that the labs are going to pour up your PVS model. And then even not listed on this, they're going to scan that in with likely a desktop scanner, which can insert more microns of inaccuracy. Scanning these days, and this isn't a study from going on 2 years ago now, the Journal of Aesthetic Restorative Dentistry by the team at Medical University of South Carolina, 5 micron accuracy, the Emerald got down to, and scan pattern doesn't alter that when you're talking about quadrants. They have a new scanner, newer scanner than this. It's the Emerald S, which is even more accurate. So this is actually pretty cool. The team down at Medical University of South Carolina that I just referred to, if you say, oh, that's hogwash, every study is paid for by somebody this is the accuracy study that they did most recently. This is actually a dissected human mandible. They prepped teeth. They checked cross-arch accuracy of the preparations themselves. So very real and lifelike, obviously. Pretty legitimate study there. Intraoral scanner. Okay, so I would call it a gateway. Just like PPO dentistry is to my patients in my practice, it's just a gateway. It's a low barrier to entry. It's not a huge cost. It's actually a great thing for you to buy this year if you have the extra funds for it. I would say that there's some missing links once you get to the end of that, because there's so many more things that you sort of need in your wheelhouse to make things happen. With just a scanner, it's still a lot of using labs, having to communicate, just like you do with analog impressions. But again, it is a gateway. CAD/CAM milling, let's talk about it. I would say probably the biggest return on investment we've ever made in our practices. If we get to Office 4 or 5, wherever, I think one of the first things we'll get is a scanner and a milling unit in the office. This is the past. Again, these were the preparations that sort of people thought had to be done with in-office CAD/CAM milled restorations. You can fly a plane on those. That is no longer the case. That's not what preparations look like these days. There's been some material concerns over the years. Companies will come out and recommend materials for full coverage restorations long-term. We won't say names, but there's been a history of that. Those things have been solved. There's long-term companies in the industry like Ivoclar, Vivadent, who make incredible materials that do not break like that. Certainly, it's a lot up to the control of the user. What you put in is basically what you're going to get out. There's no way that restoration is going to fit ever, even milled, detailed on the best mill there is. That's user error. That has nothing to do with CAD/CAM in-office milling. So these are the mills that we have in our offices. The PlanMill 30S. It's a single spindle mill. Incredible technology at how fast they've created this to mill restorations. I would say about 12 minutes is the average for a size I-12 block of Ivoclar Vivadent Emax. Beautiful marriage there. Here's a case. In our practice, patient presented, obviously broke the cusp off, large leaking amalgam restoration, recurrent decay. I don't know what you guys would do in your practice. It becomes a little bit of an objective/subjective diagnosis when we see teeth like this, kind of deciding where the tooth and the patient should go from a restorative standpoint. We'll go over that a little bit later. In my practice, a tooth like this is a crown lay, okay, a little bit different than a full coverage to the gingival margin crown. But not a partial coverage, cuspal coverage like an onlay would be. So we call this a crown lay. I decided to show this case. I feel like when doctors get into CAD/CAM, sometimes the jump to the learning curve of what partial coverage restorations are in onlays becomes a little much. Some back off quickly because they get scared and they don't have one fit, just like the picture I showed you a second ago. So I thought this would be an easier warm-up for most people. When you're doing adhesively bonded ceramic dentistry, we don't need walls of tooth that go down to the gingival margin. A lot of what that's from was from PFM restorations and zirconia restorations where you're just luting the crown and you need that actual physical retention. We don't need that any longer when we're doing adhesive bonding. So we leave our margins high and tight. Obviously, we have to go down to the level of healthy tooth structure. but we're going to try to keep as much enamel surface as we can around the margins. And then obviously it's more easily cleanable for the patient. If you're using the right ceramics and understand aesthetics and value, and prep design, you can make these look beautiful. Obviously, this is a beautiful restoration. If you're asking about the cervical area down there, I would tell you that on some of these patients, I would, in a case like this, and if that was decay and that's not, but if it was something that I was going to go after, I would leave the margin where it is on this full coverage crown lay, and then maybe do a little class 5 down there with composite. That's kind of our protocol. If you're driving the margin down to the gingival margin on this tooth, understand you just drop that buccal margin down to the dirtiest place in a patient's mouth, the single dirtiest place. Whether you want it there or not, that's your decision. So these are the sort of restorations we're doing day in and day out. When we hire associates, they don't even have the choice to send the restorations to the lab. They are thrown in. This is what they learn to do. And it works. Pretty impressive, pretty aesthetic stuff there. Hey, I took this photo, had a patient, and the dentist they had come from was a CEREC user. And so we finished, and both of them look pretty. Beautiful margins. Nothing bad to say about either of those. Hey, this is how accurate these 30S mills are. This is a 300 micron. I can't say the name of this or I'll be sued for a lot of money, but you can see what that is. Pretty incredible. That's how small it is. That was milled. The Planmeca system is, I would say to date, the most open system there is in digital dentistry. What that means is things can move in and out of the system very easily. You'll see how easily surgical guides are designed later on. And it's just a couple mouse clicks to export that to any sort of other software you need. Pretty incredible. That's how you're able to mill that little guy there. So real world applications of CAD/CAM. Obviously there's no physical impression anymore, no second injection because we're delivering that day and not bringing the patient back for a second visit. I would say with an asterisk though, you do have to move. If you're going to take 3.5 hours to do a crown, which that's way too long, but obviously you're going to have to give a second injection for that patient. No second appointment, no temporary crown. Restorative buckets. Okay, so let's talk about with the idea of where you're placing patients restoratively or where you're placing teeth restoratively without the benefit of in-office milled restorations. This is about all you have. I would venture to guess not many practitioners are getting into partial coverage ceramic dentistry without the ability and the control to do them in-house. So you're basically picking a bucket, one of these two buckets to put a tooth into. And I'll tell you that it is when you see the light and come to the other side, only being able to offer these two restorative options, you understand very quickly how much you're handcuffing yourself, how much you're mistreating teeth sometimes. Save the enamel. It's not the type of dentistry that I think we should be moving towards. Saving tooth structure, conserving tooth structure is a win 100 times out of 100. So with the ability to mill in-house, we now have 3 different buckets. We've added this middle bucket onlays, and I think, have a much cleaner route to putting the tooth in or teeth into the right bucket. And so the secret sauce and the biggest ROI I think of CAD/CAM is taking these patients that are kind of in between a filling and a crown. And we used to say, oh, let's just watch it. We'll just wait. I see a crack, but it's not ready to be crowned. We'll just wait till you give some symptoms or we see enough on the x-ray. And then we never even get to treatment. And so we sit the patient down and we talk to them and we say, hey, here are the positives of doing this partial coverage preventative ceramic restoration. And so patients believe it, they buy into it. There's insurance companies where onlays are covered at equal or greater percentage than crowns. Some of the fees are increasing on onlays to where they are higher than full coverage crowns on some. It's pretty incredible. So this is the presentation we're giving, more conservative to the tooth. Usually it's a little less costly to the patient's pocketbook. I always like to throw that in. They're covered by insurance like crowns, with the asterisk of some insurance companies will not allow onlays. Some of them will have downgrade clauses in them. So you have to be careful about that. You train your team when they see something like that. And I've talked to the patient about an onlay. We never want to take that back down or downgrade it ourselves to a filling because the patient couldn't afford the onlay. We always upgrade that to a full coverage crown. Understand too that onlays and inlays are treated very differently from insurance. Inlays are usually covered at the percentage of an amalgam filling. So the patient will pay like $800 for a little inlay. I usually do inlays if I'm feeling super lazy and I'm prepping a quadrant of ceramic / composite, and I just make the composites out of a composite block, a hybrid block, or even ceramic. So, but there's onlays for you. Perfecting the schedule. Digital dentistry and CAD/CAM in general is a change to the norm, and the team has to dive in and understand and learn that. It changes scheduling. Like I said before, the dream schedule is piggybacked same-day dentistry, same-day cases. If you look here, our standard is 2 hours for a same-day case, but really at the hour mark is when the doctor would move to the next patient and then start the process all over again. So we have team members that duties are delegated all along the way. The doctors in my practice do our own scanning and designing. I know some offices have moved to assistants doing that, and more power to them. I know there's a lot of assistants out there that are pretty incredible, better than me at doing this stuff. But this schedule gives us enough time to build in hygiene checks and do other things. You can also fill in the gaps. So if we're doing a same day case, maybe we're blocking 2 full hours because that second hour of that visit, we're moving on to something else, partial coverage, ceramic restoration in another quadrant, or some composite fillings or a quadrant of scaling, anything like that. That's really where we sweeten the pot and make these visits super profitable for us and super efficient for the patients. Okay, you are the best solution. I usually tell a story here. I'm not going to tell it because I don't want to upset anybody, but understand this, that the amount of control gained by doing this type of dentistry in-house is unmatched. It is literally unmatched. And I've gone through using labs that have a full operatory where we send the patient and they actually can even remove the temper. I mean, all kinds of stuff, custom shape. It just doesn't, it doesn't reach the levels of control that we have in-house, being able to do this. Some of my best looking crowns are crowns that I don't even mess with, that my team is doing the custom staining and glazing and characterizing. I remember when we got into CAD/CAM, I had assistants that were frustrated saying, man, I can't make temporaries anymore. And I'm like, you don't understand. You get to make number 9s for patients. It's pretty cool stuff. They're very proud of it. My team is when they help out here. So adding your signature. This is a fun case. It's a cool story. This is a golfing buddy of mine, okay? And you can imagine how many hours I put in looking at number 9 on this golfer friend. Every time he smiled, it became too much. And so I finally said, hey, man, what is going on? Can we fix your tooth? And he's like, well, I went to a dentist, and they said the only way I could get this to look good would be to do six crowns. And I understand the science behind that. We're not here to debate over-treatment tonight, but understand that I laughed at him when he said that in a nice way, but to the point of there's no way we need to do 6 crowns for a case like this. This is a single unit slam dunk all day, every day in our practice. We have lots of material options, lots of translucency options, lots of way to characterize this. There are mirror functions, contralateral functions within the software that allow us to mirror the contralateral tooth. We can do digital wax ups pre-op to bring in and scan those. So, we got him in, we scanned him, we prepped the tooth, and this is where we ended up. So again, I think that's a pretty incredible result. I would be happy for him to be golfing with anyone else, telling them where he got his crown on number 9 at, even though I'm not sure you'd ever even know that was a crown. Pretty cool stuff. So again, no 6 crowns. We're doing 1, and that's a same day visit. That's 2 hours in and out the door. We did not digitally wax up that case or anything. We just used contralateral function to mirror what number 8 was. Some tips on doing these types of cases and being able to communicate the value of the dentistry to the patients. I think this type of dentistry a little bit becomes pseudo commodity based. It's patients that do they have an extra whatever X amount of dollars? Are they okay saying yes to doing several units of cosmetic dentistry? It starts with good photography. If you're not taking good photos of your patient's conditions, you're going to have an extremely tough time convincing them of the value of the dentistry. We're taking photos like this on our patients on the regular. We're also taking intraoral scans pretty much once a year on our patients. It's a really cool thing to sit there with the patient on the screen. The colors on the intraoral scanners have gotten good enough to where you could sit there and manipulate the screen and show them exactly what's going on. If you're talking about doing multiple units of quadrant dentistry, it's a super effective way to show them, A, B, and C of here's what needs to be done. This is why we're doing it like we're doing it. So super important. Again, we talked about delegation, but these are the types of things that our team can do. My team now, we're 3D printing night guards, and I don't touch the process from patient in the chair to delivery. Every single step of the way, scanning, designing, printing, finishing, delivering, adjusting, all done by my team. That was pretty incredible. And not to mention it's done well. It's not just that it's being pushed off to somebody, but again, they take roles and get excited about it, and it's a cool thing to see. Okay, so we're going to move on to 3D imaging, and again, each piece of this puzzle is a piece of the puzzle. It's sort of as you get into it, now you may not know what you don't know yet, but once you get into it, you'll understand that there's limitations along the way without the required hardware, software to be able to do these things. You're still limited on what you can do. And 3D is one of them that is equally as important or more important. We have a cone beam at each one of our offices. Again, if we opened any more, day one, we'll have a cone beam in there. And I just signed up for like $350K of digital dentistry equipment. Anyways, we have a cone beam at each office. Standard of care for us is that the new patient likely will get a cone beam. Not every new patient. We have a sort of a checklist, which you'll see in a second, of what triggers the requisite taking of a cone beam on a new patient. But we're using it for diagnostic imaging, plain and simple. That's what we're using it for. We used to take. I would have so many patients on my schedule a few years out of school, and it would just be limited PA, and I couldn't see anything, and I didn't know what I was doing yet, and so it was just easier to take out a referral pad and say, go see the endodontist. And I can't imagine how many lesions I missed, and then how many teeth I could have treated in my office. We do a ton of endodontics here, which has actually helped with the ability of intraoral scanning and CAD/CAM. That's for another lecture. Guided implants, standard of care in my practice, plain and simple. You cannot convince me otherwise. I'm not sure how long it'll take before that's really the case. I would say if you are placing implants or looking to place implants in your practice, you need a 3D cone beam. Even if you're not doing fully guided surgery, which we can talk about the merits of, to have the ability to understand the clinical condition, anatomic condition of your patients that you're sinking titanium into, their jawbone of, you really need a cone beam. Airway screening, and screening is capitalized because it's just a screening. These cone beams are not diagnostic for showing patients they have airway problems. It is a way to screen them and bring up the conversation. It is a very cool visual on showing them their potential problems. But again, screening is all it is. Endoanatomy lesson, 100%. Again, if you want to get into endo in your practice, having a cone beam, the ability to check out, is there an MB2 or 3 in this tooth before you decide to take it on or not? What do those calcified canals look like? How bad is that lesion? Every day we're using it for the endodontics in our practice. Patients love seeing it. When we work up an implant case, we will have the implant planned on the software as we're showing them, consulting them about the case. They get to see that on the screen. There's nothing like that in dentistry from a patient education wow factor, like showing them their skull. Ultra low dose radiation, there's a lot to do. Plan Mecca has pushed the limits on ultra low dose radiation and keeping their images clear. If you've never researched it or heard about it, you should reach out to your local rep. Again, pretty incredible stuff. So here's the list. We have this on a little note card in our panoramic cone beam room. And so it's a cheat sheet for the assistants and hygienists that if any of these are seen on the pan that they have the patient in there for, then they don't even move the patient. They just tell them, hey, they're going to get another scan, and they start the cone beam process. Pretty straightforward. All our limited exams are getting it. We even have little credit card size USB discs. There's new ones that fold up and go into your wallet. Super cool. We have our marketing stuff on it, and we just give it to the patient if we're going to send them on to a specialist, save them a little bit of money. I know my specialists probably don't enjoy not being able to bill the cone beam, but hey, it's a gesture of goodwill to my patients. We're billing medical insurance for these. We use a company called Code, Crossover Dental Enterprises, who works with Henry Schein. Fantastic third-party company. Basically, we take the image, we write the SOAP note, my team submits it to an online software, and then Code takes care of the rest. These are the kind of things we're billing to medical oral cancer screenings yearly on every one of our hygiene patients: bone grafts, membranes, sleep, cone beams, trauma for sure. Down in your left-hand corner is our medical billing router. We're paperless. I just said we're paperless, and we have a paper router. We are paperless in the fact that we don't have things that travel with the patient except for this. If there's something that is done in the patient's experience that day that would trigger the need to bill medical, that assistant or hygienist would pick one of these slips up, put the information in, check off what is being done, and then it triggers the front desk to then collect medical insurance card and their license for us to be able to bill medical insurance. Digital implants. I got into implants pretty early on. I got super lucky. My 4th year at Case Western, Dr. Arun Garg was teaching a course in Cleveland, Ohio, so a bunch of us seniors took it. The dean did not allow us to place implants on patients with residents, which I was a little bit upset at. But anyways, I got out of the practice, started placing implants, and then pretty quickly got into the cone beam game and how that could change it. The confidence it afforded me, and then that translation to the patient and then my associates is, again, unmatched. It's an incredible addition to our practice, and I think to a lot of practices. There are so many patients nowadays that need implant placement and restoration. I know most folks are doing the implant restorations, but could you be doing these surgeries? I'm going to tell you, 99% of you on this call could do 75% of your implant surgeries. Once you kind of get into it and learn what you're doing, it's not that much different from some of the other dentistry we do every day. And having the digital technology, again, the confidence it gives you, the ability to work out or sweat it out before you're sitting down with the patient and actually doing the surgery is incredible. So we'll talk about that. So why surgical guides? I still talk to a lot of GPs that are slamming in implants non-guided. And I get it. My specialists still do it. But I can tell you when I get to, I would know right off the bat if I'm restoring one of my implants versus one that's coming from my surgeon. It's just that much variation in not doing things guided. Doing surgery guided, everybody wins. Every single person on the map of that experience has an easier time. The lab has an easier time restoring your implant. You do. The impression process is easier. The patient's post-operative complications are less. The trauma for surgery. I love how easy implant surgeries are, doing them fully guided. And I love the experience of the patient when you sit them up, because they expect that it's going to be so much more than what it actually turned out to be. This is why we do surgical guides. Not my cases, but pretty incredible kind of stuff that doctors get back these days. This is not guided surgery either. My lab technician, I used to do this kind of thing and have my denture lab technician make me a suck down for a guided surgery. I get it. There is an increase in control with this, but you really have not enough data to make this an accurate type of surgery. This is totally based on soft tissue. You don't have any influence of the hard tissue underneath it. Proven study after study that there is major differences between doing things guided versus brain versus suck down implant guides. There's actually some studies coming out fairly recently that show there's a huge difference in there's a statistically significant difference in fully guided surgery versus everything else. Everything else, whether you're using no guide, whether you're using a suck down guide, whether you're just basing it off of soft tissue, with whether you're looking at the cone beam and just kind of visually guiding yourself, none of those are different from each other. So if you're doing one of those and thinking you're better than the other way, you're not. You're not. It's a fully guided workflow where we're actually waxing up digitally the tooth in its full form before we jump into surgery, which is the most accurate way to do it. Huge variation in error between guided and non-guided. These are reasons why we're doing guided surgery, right? So we don't have to worry about plunking a nerve when we're placing posterior mandibular implants on patients, that we aren't going into the sinus with our drill and or implant when we're doing maxillary posterior implants. There's a lot of anatomy that we're looking out for. Significantly less post-operative complications for patients, okay? What I've really been driven by is the straightforwardness of how it makes my restorations for implants. Being able to control everything about depth, emergence, angulation, when you're talking multi-units, it's really incredible what it's allowed us to do. So here's a standard case. We're taking an intraoral scan of the patient. That's a team delegated duty. We are waxing up a tooth in its full form, digitally planning the implant, the guide, 3D printing the guide, and then executing surgery. Here's another one. Pretty incredible results. A multi-unit case, same idea, same concept. Doesn't matter how many teeth we're doing full wax up like this before surgery. And this is why, because it is super straightforward when we're doing it. So let's walk through it. This is in the newest Romexis software. This is the full process of what we would do. Start to finish, it takes me about 10 minutes these days. So all in, about 10 or 15 minutes to do this planning. I would do it between patients or on a lunch break. So here's where we are. We took a full arch scan, opposing and buccal bite. We're going to digitally wax up the case. We take it to the 3D module. Okay, so within the same Romexis software, we've just changed modules over on your left-hand side. We have the hard tissue cone beam data on your right, and we have the intraoral scan data on your left. We pick points on each object, points that would match. You have to start with 3 points, but you can, I believe, go up to 10. And then beyond that, there's a fine-tuning algorithm that the software takes your points as a general recommendation and makes the match even more exact. At the very end, it'll show you a color chart, green versus red, to see what kind of mesh you get. Super intelligent software. They have a library of the majority of implants that you would be placing these days, including their surgical guide sleeves, or like a Stecco brand wholesale sleeve. A lot of the drill lengths are input as well. So if you're placing, say, a BioHorizons implant, they're going to have all the drill lengths that are afforded you in the BioHorizons specific kit already built into the software. So if you're going to move the height of the guide sleeve, then you just click one button and it jumps you right to the next drill. So we've planned the implant here, the guide sleeve. We've designed the guide, okay? And then we would take the guide, and like I said before, it's exported right out, just like a Word document. But this is an STL file that we're exporting out of this software to a 3D printing software prior to surgery. I'll tell you what I do on most of my surgeries, and this was one of them. We are so certain of where we're going to be restoratively that we're taking the final digital scan or digital impression at time of implant placement. So planning the surgery, seeing the patient back, placing the implant, taking the final scan right there, right then and there. So it requires 4 scans, right? This is a tooth number 4. We're going to get a prep scan of where the implant and the adjacent teeth are, an opposing scan of the lower right quadrant, a buccal bite scan of the 2 arches together in full intercuspation, and then a scan body scan. If you've never seen a scan body, this is a scan body, usually made out of a type of resin that can be sterilized and reused. So this scan body will be inserted into the implant. This is a hexagonal implant here, so there's 6 different ways it can fit in. We try to keep it as facial as you can. Those flat sides are what the computer systems are reading when you send this to the lab to tell them the depth and position and angulation of the implant. So 4 scans. We're going to send that to our lab. This is what we get back. So about 24 hours after I've done surgery, I'm going to get back our proposal. And we're mostly screw retained restorations that are cemented extraorally and then screwed in to the mouth, to the implant intraorally. So we're going to get screenshots of not just the custom abutment design, but also the ceramic restoration that fits over top. Okay, we're going to approve that or ask for changes. And then immediately after that, my lab will send me the STL file for the restoration. And again, because PlanMeca system is so open, I literally just import that file into the software and send it directly to the mill. So I mill it on detailed. About a day after that, I get the abutment in the mail. My team cements it extraorally, and my team sees the patient to screw it in. So all in, I was there for 30 minutes, 28 minutes for surgery, and then 2 minutes at crown delivery to insert the composite and verify the occlusion. But that is literally it. The rest of the entire process was done either with the digital system or my team or both. And you can see the collections on this case. I think that's a pretty good ROI of my time. Efficient and effective doing these digitally. Here's another cool one. I don't know if you've seen this technology. A lot of labs are using. It's called angled screw channel. Sometimes in the anterior maxilla, there is not enough bone such that the implant has to be forced angled facially. And then if you wanted a screw retain restoration, obviously that becomes a little tough with those type cases. So the labs have come out with an angled screw channel, and it's literally that. It is that the angle of the screw into the restoration is at a different angle, different path than the restoration sitting into the implant. It's a little bit hard to conceptualize, But the torque drivers for these have like a side hex on them. So they engage them kind of at a 45 to seat the restoration. Really cool stuff. Again, this is a case that my lab would send me these design files, right after surgery, right after the day of impression. We approve them, and then we're milling the restorations in office. Okay, so very cool technology there. This is a photo of how this was right. It hadn't even been removed from the mill. The abutment on the left, obviously the lab made for us, but we did mill the restoration. But these are how good the margins are straight out of the mill. Pretty cool. And there's a screw hole in the bottom of that you just can't see. Okay, so why surgical guides? Okay, we talked a little bit about them, but these are the reasons that we understand now why we do them, why they are standard of care. Because super confidence booster, being able to do things that maybe you didn't think you could do otherwise, because you have the benefit of the digital technology assisting you, predictable surgical and restorative results. The options are endless as far as restorations go. These are some of the things we do that are cool nowadays. We're doing anything from custom healing abutments, where pre-surgically we can get a custom healing abutment made that's actually the same surface emergence as the intaglio of what the final restoration is going to be. I'd say that's bonkers. Custom abutments, custom locators. I'd never heard about them until I started working with this lab. Custom locators. So day of surgery for an upper overdenture case, we're actually placing the implants, then the scan bodies and taking the scan. Custom locators to correct the angulation. I mean, just the pickup impression at the next phase is so incredibly straightforward. So really cool stuff. And this is the way that, I'm going to check my time. This is the way that we're able to do it, okay? This is a virtually planned case, but what you may not pick up on is that is a virtually planned scan body. So from there, I can export that data to my lab to say this is exactly the position and the depth and the timing of where this implant's going to be. So make me X. You could go as far as having the final restoration pre-designed, prefabricated, cemented, and ready for try-in verification at surgery, delivery at surgery, whatever you want. You can do the custom titanium healing abutments like I mentioned before. This is how we're afforded the ability to do that because fully guided systems nowadays are timed. So what timing means is that there's a position on the implant insertion tool that becomes equitable to a position or marking demarcation on the guide itself, or in this case, the guide tube. So you're placing the implant at the exact right position and angulation. These are the types of cases that we're doing because we have the ability to plan things like this. Full arch case planned pre-surgically. So we've met the patient. I haven't shaken his hand because we don't shake hands now. I fist bumped and we took some scans and then we planned this case. We get to place 6-inch implants virtually with the guide tubes and the scan bodies. I'm going to export that data to my lab. Again, the openness in this software is absolutely incredible. It's just an export. It's just a HIPAA compliant export and send to my lab. And then they can do, again, endless things. Here, we're going to create custom angled multi-unit abutments. Again, this is all pre-surgical. Haven't even touched the patient. We're going to design a pre-surgical, which will be 3D printed PMMA provisional hybrid, okay, to be ready at the day of surgery. Again, crazy stuff. Really, really cool. Out to the extremes of what digital dentistry can offer. In my practice, they've sort of become commonplace because of the technology we have and the ease in which we can do them now. The straightforwardness of the results we get from them allows us to build these into our practices. This is a 3D printed hybrid. Again, we would take that, export it out of our software, 3D print this, characterize it. My team characterizes these now. I don't even touch them. And then we'd have it ready for the day of surgery. Pretty cool. But that is unicorn land. That is again, extremes of what digital dentistry can offer. That's not something that I would push to a first-time user, but it is something that you can do. So here's the real secret sauce. You put all of those pieces of equipment together, and now think about the ROI of, you have a 2-hour same-day case that starts at 8. At hour 9, you're out of the chair. The crown's in the mill. Your team's taking care of the rest till you have to cement. You go into the next room, and you're taking a scan body scan on an implant. And then you swap to the third room. And it's an endless cycle. It is very efficient and effective. The coolest part, again, is that everybody wins in this whole thing. It's not that we're doing now a restoration that just saves us money and the patient has to deal with it, or that we're having to do something so customized for the patient that we're losing money on the case. No, we literally all win in this equation. Pretty cool. Lots of cool toys. Okay, so where do we start, right? It's so much. I get it. It is a lot to digest. I came from a practice where we were already super successful, and I was up against partners who didn't believe that digital dentistry mattered to them, to their bottom line, that they could do it well without it. While that may be true, I can tell you the heights you can get with it are unlike that without. The requisite steps, whenever you put in any sort of new technology or workflow, you got to learn the system, okay? Too much, while delegation is nice, immediate delegation without the mastery yourself of a piece of technology or a workflow will only result in ticked off team members. And then when they come to you with a question that you can't answer, they're going to throw it away and they're going to take the PVS out next time. And then you're going to be too busy to tell them no. So you're just going to take the impression. That patient's going to hate you for that impression. I'm just kidding. So you got to learn the software. Okay. At that point, you can delegate and equip the team. That's how you're successful. They take it from there. My team's bringing me new ideas, new workflows every week, every day, ways that we can be more efficient. Those are people that have bought in, and it's cool that I just buy a system, a piece of equipment, and they get to learn it, and they love it so much that they then tell me how to do things. Here's the typical learning curve when you get into something like this, whether it's digital implants or digital in-office milled restorations, or even just scanning. You don't know what you don't know. You get super excited and learn how to use it. And then maybe you have a case that you have some difficulty with, a crown that you scanned and the lab made doesn't seat. I've had it. And you just get frustrated, and then you go back to how you did it before. And that's kind of where I like to live, because I've been there. I've felt that frustration and pain. And I love to see doctors go from there to the exponential possibilities afforded them with this technology. So I definitely live in number 3 there. Things to keep in mind. It's a journey, okay? Every office is different. The speed at which you get in to it is going to be different, right? There's doctors that are just out of school and don't have $250,000 to go all in on this stuff. There's guys that are out 30 years and don't have $250,000 to go into this stuff. I would say reach out to your local rep. There's KOLs, key opinion leaders, basically in every region of the United States and abroad. So if it's something where you wanted to, I know COVID makes it a little bit more difficult, but if it's something where you wanted to go see this in action, I know these guys, I work with them all the time. I know they'd be confident and comfortable and willing to let you come learn and experience what they're doing. Do your research. There's a ton of marketing dollars in digital dentistry these days. It's the fastest growing segment of dentistry. That's not going to slow down anytime soon. I call it smoke and mirrors, but there's a lot of marketing that's thrown in your face that just shows you the expanse of what you can do and not really how to do it. and it can lead to frustrations. Scan-only pitfalls. We talked about the limitations of just having a scanner. So scan-only can be a great barrier, a great entry point or a gateway, but understand that there's a ton of limitations. So if someone's just trying to sell you a scanner, understand what that can get you, and understand the other pieces that could be in play as a necessity. These are my buddies, Dr. Manito, Dr. Renee, and Dr. Zach at a Medical University of South Carolina that helped run my CE company with me. These guys are fantastic. This is a course we did out in Denver, Colorado last year. We did a ski and learn where we had mills and scanners and laptops shipped in, and we actually scanned prep typodonts with high speeds. We scanned and milled, and we skied, and it was a great time. A really cool experience. This is another one of our courses. So I have high expectations of you, but none greater than you may achieve. I wish you all luck. Here's my email right here. My company, as you can see, Are You Numb Yet? I'd be happy to answer any questions you have now or later. There's my email. You can feel free to reach out with anything, honestly, even if you need just like a virtual hug at this time. I'm happy to oblige. So thank you for your time. And I think Adam's going to open it up to some Q&A.
Absolutely, and thank you for your presentation. We are at the hour mark, but we have quite a few questions, so I want to try and get through a few of them. The first one is, when you say Planmeca is an open CAD/CAM system, what exactly do you mean by that?
Yeah, so it's a little bit of a misnomer. There's everything within the umbrella of Planmeca to do what you would like to do. There's a module for basically anything you'll want, a smile design, an ortho module, anything like that. The benefit of an open system, what it means is that you can import and export things out of the system, which is in difference to a closed system where you are tied inside the software such that you can't export things out. You couldn't use a different digital dental software. For instance, you design a guide in Planmeca, you just hit an export button and you get to export that guide right into the direct 3D printing software, whatever 3D printer you're using, or directly to your lab. And you could also just import in, like I'm doing for digital implant restorations where I mill them in-house, even though the lab's designing.
One attendee currently has a PlanScan, and they're wondering if it's worth an upgrade to an Emerald S or versus an Emerald. Do you have a preference, or what's the advantage of each?
Yeah, I would say an Emerald S for sure. I compare it to iPhones, right? And so the Emerald has been out for a few years. It's still very good technology, but that technology has been improved with the Emerald S. I think if you want the newest that you can get, that most of the research and algorithms and expansion in technology is coming to, then I would say the Emerald S. It's if you think about, there's still a lot of doctors using PlanScans, and we still have our PlanScans, but you're looking at going on almost a decade-old technology, and so. It would be a game changer for that doctor to be on either of the Emerald or Emerald S, but I think even more so the Emerald S. It's an incredible scanner.
What was the biggest hurdle when implementing CAD/CAM into your office?
I think the workflow and how you have to be a little bit creative to get the patients through sort of, from in the door to out the door, and every piece that's involved with making that happen. For instance, when I leave the room at the hour mark, there's 10 steps that have to happen by my team. And those steps have to happen in a timely fashion for the 2-hour same day appointment to work, right? If no one hears the lid open on the mill, and to immediately remove the block and start the next step of the process, the seconds start ticking. equally, when the restoration comes out of the furnace, if no one hears the furnace pop open and start beeping at you that the restoration's ready, again, the seconds start ticking. So I think it's that the creative way to make things happen. When we're doing endodontics with CAD/CAM dentistry, which I think is one of the coolest things we do with digital dentistry, we'd actually prep the tooth first. We'd make a basic access, or maybe even not the access yet. But either way, we're doing the preparation first, scan, design, and mill, and then we'll come back and do the root canal while we're waiting on the restoration to mill. We would backfill adhesive resin build up from there when we go to cement the crown. But I think just the workarounds to where the daily workflow, the difference in how that works versus traditional dentistry.
Can you explain a little bit how you efficiently manage your time with multiple digital cases in a day?
Well, you have to understand the amount of or pieces of technology that you have available to you. We've graduated to having 2 mills at all the offices because we ran into things like that where you just couldn't, everything was taken, or there's only one workstation and the associates designing on it. So we function with 3 workstations, 2 scanners, and 2 mills. So there's 3 doctors at each location. Everyone could have basically their own workstation, and then the scanners travel and the mills get used. It's a balance. I do quadrant ceramic dental cases same day. I would do a single unit like we looked at number 9, same day, even if we're getting crazy on customization. If we're going to do a 6 through 11 smile design, I actually don't do those same day. I still do them digitally, and I still design the restorations myself, but I'm going to deliver that case in 48 hours or 72 hours or a week or 2 weeks, whatever the schedule allows, or however many hours I want to stay and work on a case. It's again, I think I said it's a delicate balance on once you get into digital dentistry, you learn that there are some things that are cool to do, but also super inefficient uses of your time, right? We should be doing the most profitable dental thing we can be doing at all times. I know we like to sit and do other things. We like to dabble in designing cases, but when it comes down to it, we should be doing dentistry at all times. So, I don't know if I answered that question or not, but.
I believe we had a question about what 3D printer you use, and I think that was the Creo, correct?
Yes, Creo. I have a couple other different printers. I don't know if I'm allowed to say their name here, but I have 4 different 3D printers in my office right now. Most of them on the market, including the Creo, are straightforward enough add-ins. The 3D printing part has probably been the easiest add-on or adjunct to our workflows. I don't have any participation in the printing of models, guides, anything in our practice. That is completely 100% on my team. That was taken over sort of day one, and we haven't looked back. So yeah, that's where we're at 3D printing.
When you use surgical guide to place implants, do you open flap or do you go flapless?
Some of both. Yeah. It's dependent on the case. If I'm doing a full arch case like we looked at where we're pre-surgically planning, usually if I have any question, I will reflect back after we do the osteotomy and or even place the implant. For the most part, I would say the standard answer is no. There are reasons of, soft tissue reapproximation where we have to flap. There's thin margins of bone where we're flapping and we don't have a choice. So I would say we're not cheating by any means, but part of the benefit of doing the surgeries guided with the control that we're given with that is that we don't have to flap.
Great. And we're about 10 minutes over, so I do want to be respectful of everyone's time. We'll have time for one more question, but if we were unable to answer your questions, please feel free to email Dr. Murray, or you can email us at webinars@henryschein.com, and we'll work with him to get answers back to you. The final question is, what do you find is the easiest way to train your team with implementing new technology?
Oh, that's a good one. I would say come to RUNUM yet. No, it's there are continuing education opportunities within all of these companies, these vendors, distributors. They understand that, they need you to understand their software, hardware, or you're going to be frustrated. So I appreciate that the question already started with how can we train our team, because that's a necessity. I would say it doesn't really work if it's just the doctor learning, and it doesn't really work if it's just the team learning. So we've every time we've added something, we've taken them to Plan Mecca, my team and I, or my associates in the team, or whatever it may be. It's a fun experience. I know CE is changing. I don't know what CE looks like in the next 12 months. I think that may be a task that we'll have to really get creative on in preparing teams for this. There's opportunities through Plan Mecca to have trainers come to your office. I've been in multiple offices with doctors and teams. I think that's a fantastic way to get boots on the ground and see how they do it and how they want to do it, what their limitations are. Yeah.
Awesome. Well, thank you, Dr. Murray, for your insightful presentation and answers. If anyone does have questions about adding Plan Mecca imaging or CAD/CAM equipment and technology into their practice, please reach out to your Henry Schein representative or email us at webinars@henryschein.com, and we will connect you with a sales rep in your area. Everyone attending tonight will receive a link to view the recording in the coming week via email. On behalf of Henry Schein and Plan Mecca, I'd like to thank Dr. Murray for his time and thank all of you for attending. Hope everyone has a great night.